We will be covering the tissue targeted specific shoulder mobilizations adapted by the IAOM United States chapter. First, note the patient positioning on the table. We are using a strap to stabilize the scapula over the acromion and also a wedge posteriorly. Also note the patient is close to the edge of the table, and also a bolster is used under the legs for comfort. Also preferred is a high-low table for therapist comfort and positioning. The first mobilizations will be to restore flexion. The first one will target the coracohumeral ligament. The pre-positioning for this mobilization first includes flexion, followed by horizontal adduction, then followed by partial external rotation. Note the mobilization will be in a posterior and lateral direction. This respects both the inclination of the glenoid and the labrum. You can see through the therapist's forearm the direction of the mobilization. Also to note, the therapist, once the mobilization is completed, will ask the patient to contract the agonist of the motion. In this case, the patient will lightly flex up into flexion before the mobilization is ended to both reapproximate the joint and for neuroreeducation. The next mobilization will be targeting the posterior superior capsule. The prepositioning will first include flexion, followed by horizontal adduction, and now partial internal rotation. This position puts the coracohumeral ligament on slack and more targets the posterior superior capsule. Once again, the immobilization is in a posterior and lateral direction. Also to note, with all mobilizations, the therapist wants the hand position as close to the joint line as possible, just distal to the lateral acromion. Also to note, a grade 3 mobilization is preferred to increase range of motion. The final mobilization to improve flexion will be targeting the anterior superior capsule. The prepositioning will first include flexion, followed by partial horizontal abduction, and also external rotation. Once again, the mobilization will be in a posterior and lateral direction. That concludes the mobilizations to improve flexion. We will now cover mobilizations to restore abduction. The first mobilization will be targeting the anterior inferior capsule. The prepositioning will first include max abduction and scaption, followed by submax horizontal abduction and submax internal rotation. The mobilization direction will be both inferior and slightly lateral, once again to respect the glenoid and labrum inclination. Also to note, the therapist, and with all mobilizations, want to support the patient's arm as much as possible to allow patient relaxation. The final mobilization will be targeting the posterior inferior capsule. The prepositioning will first include max abduction and scaption, followed by submax horizontal adduction, and finally submax external rotation. Once again, the mobilization direction will be both inferior and lateral. And also to note, with all prepositioning, the patient's in range will dictate the amount of preposition. That now concludes the tissue targeted specific shoulder mobilizations.